Please dial in, let us know who you are. We're going to start at 9:30 in just a couple more minutes. So look forward to hearing your views on fixing flow today. Good morning, everybody. It's Friday, the 4th of November. It's 9:30, and we're in the Edge Talks, and we're going to be talking today about fixing flow. And we've got a specialist in this area, Sasha Karakusevic, and I hope I pronounced that right, Sasha. I'm hoping that you will be able to use the chat room to tell us what you think about this area, and also use #Edge Talks or @TheEdgeNHS to let us hear and know your views on today's really important issue, fixing flow. My name's Janet Wiseman. I'm an associate in the Horizons team. I'm your host for today. And Dominic Cushion, he's going to be also supporting today, and he's going to be in the chat room. So please use the chat box to contribute, and also tweet using the hashtag #EdgeTalks. And the handle @SchoolForRadicals @TheEdgeNHS. So this is me, Janet Wiseman, and this is Dom Kushnan, our specialist here looking after the Twitter and chat room today. So I just want to introduce Sasha. He prefers to be known as Sasha. We've been working with Sasha in the Horizons team since June this year. He's a fantastic guy to work with. I've been working quite closely with him on a number of projects. He's also been a senior fellow in the Nuffield Trust, working on health systems, technology, and patient flow. Thus, his recent publication, Understanding Patient Flow in Hospitals. I'm looking forward to hearing a lot more about that. But so he's held a number of senior director positions, and he's here today, and he's going to tell us a little bit about his experience of tackling a very difficult and complex issue that we're all faced with today around patient flow. So we're going to be looking at the recent Nuffield Trust report, looking at decision-making in complex environments and what to do when the data doesn't fit. So I'm going to hand over to Sasha and take it from there.
Thank you very much, Janet, and good morning to everybody. It's a real pleasure to be here talking about this really important topic. I found this first picture from something called a WASjig, and a WASjig, for those of you who haven't come across them, is a back-to-front jigsaw. The picture on the front of the box isn't the picture you're going to make, and just as I was doing the work with Nuffield Trust, I came across one called congestion. Now, I think this accurately sums up many of the challenges that we're dealing with in understanding flow, and I'm going to take a little bit of time to explain why. If you're looking for Christmas presents, this is a great place to start. I've been involved in flow for a long time, and had a lot of successes and a few failures. And in trying to understand what the current problems are and why they're so difficult, I've been really lucky to be able to spend some time with the Nuffield Trust, working with Nigel Edwards and colleagues to stand back and have a little look. And I want to talk through that experience in the hope that it triggers some ideas that are useful to you where you are. So understanding patient flow in hospitals is what this talk is about, and I just want to highlight a couple of other pieces of work that are likely to be published soon, and in particular a piece of work that colleagues at the Health Foundation are doing, which looks at flow from a whole systems point of view. I'm going to touch a little bit on whole systems, but most of today's talk is about the in-hospital part of it, largely because that's where the major constraint is at the moment. I want to start here, and one of the first things I did when I started my work with the Nuffield was to say, well, there are a few trusts that are achieving the 4-hour standard, and many that aren't. But how different are they really? And in 2014-15, the top 12 trusts breached 4.2% of the time, so they were just achieving just over 95%. And those furthest from the target had a breach rate of almost 18%. The differences are quite interesting. So those trusts furthest from the target, almost twice as big as those hitting it. Interestingly, their average length of stay was only 0.3 of a day different. Once you've adjusted for things like complexity, the difference probably boils down to only 3 or 4 hours. And we calculated that just solving that would not, on its own, solve the problem of flow. So we looked a little bit wider at what's happening in the systems, and you can see some quite interesting differences. Those achieving the target are using more beds per person than those that aren't. They actually have a higher admission rate, which is slightly counterintuitive, and they have more space available at midnight. And this got us thinking about why are some of these differences there and what can we learn from them. And so we'll tell you a little bit more about that. I'd like to move on. So one of the big challenges when you're in your individual hospital or any individual point in the system is trying to understand the perspective. And I thought I'd just illustrate this with a picture. This is part of a mosaic tapestry, and I'm sure none of you can work out what the picture is, but if you stand back a little bit, you can see who that is, and it's actually a picture of Desmond Tutu. And I think this illustrates very nicely the problem of needing to bring together information and ideas from lots and lots of different parts of the system, and to do that in a very non-hierarchical way. Bits of information aren't more important than other parts of the story. What is critical is to build a whole picture of what's happening to inform where action can be taken. And I feel that very strongly, and we'll talk about that more as we go along. What I want to say about the data in this talk this morning is that most of it has originated from stories. So I firmly believe in management by walking about, and in trying to improve flow in hospitals I've worked in, just talking to people at lots of different points in the system to understand their perspective is tremendously powerful. And then starting to add numbers to try and inform those stories and bringing the different parts together, I hope, gives a rich picture. And we'll talk a bit more about that as we go along. The work we've done in the Nuffield Trust links together with other pieces of work that are recently published. And this paper by Sarah Adi Krendler was brought to my attention recently, and argues that flow depends on linking a defined population with the appropriate capacity and an efficient process. And instantly you can start to see that there are lots of ingredients to get right. I'm going to start off by following this for today's talk and take the report slightly out of order. So I'm going to talk a little bit about a population and then capacity and processes. Firstly, to say the population is changing. This chart just shows the likelihood of spending time in hospital, and it's no surprise that as we get older we spend longer in hospital. But you can see that it's actually quite profound. I suspect that most of us involved in this call today are probably likely to be spending no more than half a day on average in hospital per year. Yet by the time you reach 85, the average is just under a week per person per year. You can see that over the last 6 years there have been small improvements, so people are spending slightly less time in hospital. But when you look at this chart in relation to future population change, you can start to see a potential problem. And this chart shows that. So what this is showing is, on the left-hand side, the number of beds that are used across the country in relation to age. So virtually about 10,000 beds for people up to about 14, ranging at the moment up to just over 100,000 for the total population by the time we get to 85. And you can see by 2020 an increase, and by 2030 a bigger increase, leading us to about 140,000 beds if we continue working the way we are today. And that's a big change. The key question is, can we optimize our current systems to deal with that kind of increase, or do we actually have to change fundamentally the models that we're operating with? And we'll discuss that a bit more as we go along. I think as somebody's put in the chat box, this is largely a result of the post-war baby boom. By 2030, that group are increasing massively, and clearly it's going to have a big impact on what we do. And this underlies one of the key problems, I think, that are facing us at the moment. So people were routinely hitting the 4-hour standard in 2011, and by 2014-15, unfortunately, they weren't. And you can see what's happened. The bed use has been gently increasing for the last 4 years, and the number of beds available has been pretty flat. And I think that creates a constraint, more people trying to fit through a narrower gap, and we'll talk a bit more about that in just a moment. What's interesting is that bed use is partly driven by population, and there is some evidence that as the system is getting more congested, it actually takes longer to be treated, which is obviously a double whammy. The classic question, which line would you like to change and which line can you change? It's tempting to say we need more beds, but firstly we have to find the funding to build them, and that will take a lot longer than the increases that are starting to appear in these charts. And secondly, we have to train the staff to work and operate all of those beds. Also not that easy to achieve. So even though we might like to build more beds, in reality we need to think much more about how we use the capacity that we've got. I want to use a picture to illustrate this, and we will all be way too familiar with this picture, and it tells us a lot about the problems that we're facing in hospitals. Firstly, note that the design of the motorways has been remarkably stable for a long time, and typically they have 3 lanes. And you can see a recent innovation on this picture of a managed motorway where we've brought the hard shoulder into use. tempting to say, well, it's the extra cars that are causing the problem. It's tempting to say it's the lorries that are causing the problem. In reality, it's the interaction of all of the traffic in a particular situation that causes the problem, and we need to think about that. What I thought I'd do then was just to illustrate some of the concepts of flow, putting a few numbers to this picture. And those of you who've read the report will have seen this table. On a free-flowing motorway, which is the first column, typically the left-hand lane is travelling at a slower rate than the right-hand lane, and there's therefore variation in the speed across the lanes, and you can see that the fastest driver complying with a 70-mile-an-hour limit should take about 28 seconds to cover a kilometre. As the motorway gets more congested, then the speed in each of the lanes starts to come together, so the variation reduces, and the fastest user goes up from taking 28 seconds to cover a kilometre to 37 seconds. And as you get up to heavy congestion, you can see that the number of vehicles in a kilometre obviously increases massively, as does the journey time. And this is really illustrative of some of the problems. If you imagine a congested emergency department and think through the amount of time that it takes to care for all of the patients, in a free-flowing situation, it might be around 28 minutes in this illustration. It's nearly 7 times more than that by the time you get to a heavy congested situation. So the workload for staff in a constrained area massively increases. And as we all know, it's massively more stressful driving in those kinds of situations. So we have to think also about what kind of environment are we creating for people to work in, and more importantly, to be cared for. Let's try and apply that to the problem that we are dealing with on a day-to-day basis. I want to talk about it in these terms. How do we better measure and manage flow? What can we do to transform the way that we look after people, and to what extent can we avoid the need for people to travel through the system? Starting off with a run chart of occupancy that we calculated across the country, and it's a relatively complex chart, but what you can see is week on week the pattern of activity is pretty similar. You can see that over the summer the level of activity drops. You can see a massive fall on Christmas Eve when virtually nobody's left in hospital. And you can see the winter pressures period over to the right of the chart just after Christmas. The red line in the middle of the chart with a couple of little steps in it is the number of beds that were recorded as available across the country. And the dashed line right up at the top of the chart is the number of beds you would have required in 2014-15 if you decided to apply the 85% rule. And you can see at that level there would be enough beds for all sorts of situations, but you can also see a huge number or a huge amount of white space above the number of beds that we actually used, which suggests that we'd have a huge amount of spare capacity for much of the year if we use that rule. And so there's a judgment between the number of beds that are being used and the old, if you like, the old rule of 85%. Where do you draw that line? The other important point to make about this is the should we be planning just to merely cope, or should we be planning to maintain a consistent level of service? So in many other walks of life, we as consumers expect to get the same standard of service pretty much whenever we want to consume it. And why should hospitals and healthcare be different? So we need to be building in sufficient resilience to cope, not just today, but next month and next year, to make sure that the quality of the experience is high. The other point to note, and I think this is really important, we used to measure, in fact we still do measure, hospital occupancy in many of the national returns at midnight. And in the old days, when matron went round at midnight and checked that everybody was in bed, that probably made sense. But since then, we've massively increased day surgery on the day of admission surgery. The amount of emergency patients spending less than a night in hospital has increased massively, and yet we haven't changed the measurement standard. And I want to talk a little bit about that in a moment. But just to say that for planning, actually plotting the data over a year and ideally even longer will give you really useful information. And it's an important discipline of being able to visualize what's happening as opposed to just seeing flat data on a spreadsheet. So this chart takes that a little bit further and looks at the cycle of bed occupancy during a day across a couple of month period. So it's a smoothed data looking at the patterns for a day, each day of the week across a 2-month period. It starts off with the 0 is the bed occupancy at midnight, which is what you'd normally see if you looked at the hospital occupancy. I've calculated this to say that increasing bed occupancy is a negative thing because we need usually to find more beds. So you can see that between midnight, which is 0 on the chart, and 8 in the morning, occupancy in most hospitals increases, and it's actually worse on a Friday and Saturday night for not massively surprising reasons, I guess. And then you can see from 9ish in the morning, there's a net reduction in occupancy as people start to be discharged. And actually by 6, 7 in the evening is the lowest point of occupancy. Now, if you walked into most emergency departments, I think you would be surprised by that because that's when the biggest queues happen. So what's happening? And we'll come to that in just a moment. One of the key points of this chart is to differentiate between the idea of peak occupancy, which is actually not at a point when most of the flow is happening, and the notion of peak flow. Peak flow is when the graph is almost vertical, so lots of people moving each hour, compared to when the graph is almost horizontally flat, when virtually no movement is happening or net movement in the hospital. You can see a big difference between the weekdays and the weekends in this particular hospital. In fact, over the weekends, there is no net improvement in occupancy over the weekend, and that's in many cases a problem. So what happens when the system isn't designed to deal with the flow rate? This chart tries to explain that, and what you've got is in the top line the flow rate per hour. So you can see that at 4 or 5 o'clock in the morning, just under 2% of the day's work per hour is happening, compared to 5, 6 o'clock in the evening when nearly 8% of the day's activity is happening. And just to see what happens, this chart then said, well, actually, what happens if we design the system so that only 5.5% of the day's work can be done in an hour? And this applies particularly to things like hotel services, potentially, you know, how many doctors you've got in the system, potentially how well resourced your radiology department is. But it's not, this chart isn't specific. What you can see is that if there is 5.5% supply of movement and a demand of up to nearly 8%, somewhere around 6 in the evening, you've got nearly 10% of the day's work waiting. And that starts to resolve somewhere around 8 o'clock, but there's still 4% of work waiting at 2300 hours. So we've ended up with a really big queue. And if you think that the work rate is around 5.5% an hour, you're adding almost 2 hours to patients' waiting time who arrive around 6 in the evening. And that shows, I think, a pattern that many people will be familiar with in their hospitals. So the interesting thing also to say about this is it's not just about the beds. Potentially, you could have beds, you just can't get people to them. And that's a little bit like the motorway situation where you end up stuck in a traffic jam for a period, and then you get to the front of that traffic jam and find an empty road, and you wonder what that was all about. This is exactly the same. There may be beds at the end of the system, but because we haven't matched the internal flow through the hospital, you can't actually get to them. And we'll talk a little bit more about that now. It's a slightly rhetorical point, but does your bed change team look like this? And I defy anybody to stick into the chat box that theirs does. Actually, there's remarkably little data about what happens during the day. How long does it take to get a bed ready for the next patient? How long does it take to move a patient? And one of the big challenges we have is that actually the systems we use in small hospitals and systems we use in big hospitals are remarkably similar. I quite often like to test whether something that appears sensible in one situation is sensible when you look at it in a different place. So just imagine the twice daily landings meeting at Heathrow Airport, where at 8 o'clock we say we have about 500 planes arriving today, and we'll check how that's going along at 2. But in the meantime, we'll leave the command centre and see how it goes. And I don't think any of us would want to be on a plane that looks like that. Or on a plane landing at an airport that's run like that. And so where you have a lot of movement, the need for real-time coordination increases substantially, and the ability to save only a few seconds and only a few minutes matters a lot. How well have you choreographed the interaction between teams in your hospital? And it's a very easy question to ask. It's actually very difficult to do in practice. But these sorts of interactions might be one of the ways that we can at least make our existing systems work a lot better, and should be an awful lot easier to do than just building more beds. This doesn't have to be difficult. As I said when I started this story, lots of the information in this report has come from talking to people about their experience and trying to piece the individual parts together. A lesson I learned a few years ago about how do you run an airline. Well, they all have control centres, and the interesting thing about them is they don't try and build one big computer system. They basically say that individual types of aircraft have to have crews trained to fly them. So if you're flying 737s, you actually don't need to know much about 787s and so on. If you're running a hub in London, you don't need to know that much about Manchester and so on. So you can actually create a modular solution where you have experts in each individual area, and then you coordinate between them. And I think that starting to think about what each of your individual teams knows and how you can bring that information together in a more structured and a more real-time way will take you quite a long way forward. But if you can move to real-time data, particularly where there is a lot of movement, it will help massively. And I'll explain a little bit more about that in a moment. Trying to get the slide to move on. There we are. One of the challenges of why this is important is actually that average length of stay is a very poor measure for planning flow through hospitals. We're now in a situation where 58% of activity is 0 day, so either day case or not staying over 1 midnight. And that activity, and it's a mistake I've seen applied in a number of places, it's very easy to say because they're not there at midnight, they require no space. And that's clearly a mistake because people have been through and left. It's a little bit like measuring traffic over the Avon Bridge on the M5. If you measure it at 5 o'clock in the afternoon, it's very different to the picture you'll see at 2 o'clock in the morning. So you have to work out how much space these 0 day patients are using. In this report, we assume that it's 12 hours because actually there is no nationally recorded data. And it's probably a lot less than that. But one of the things that's changed more than anything else is the volume of 0 day patients. So in the period we looked at in the report, 0 day activity increased 17% over 6 years. And unless you've matched that in your assessment units in particular, it's highly likely that you will end up with queues. At the other end of the extreme, only 10% of patients now stay in hospital over 7 days, but they use 65% of the beds. Going back to the motorway analogy, when I talked about a normal motorway, traffic varying 50, 60, 70 miles an hour, this is a very much greater variation. Those patients staying over 7 days typically can spend, I think the average is about 30-something days. So you're looking at about 50 to 60 fold variation in the speed of people moving through the hospital, and that has huge impact on what's happening. Very easy to think that we can go back to where we've come from, and I would caution against that. A lot of the reasons that have driven us towards day surgery, driven us towards assessment units, driven us to need to bring people into hospital to get the right kind of diagnostic and interpretive skills are not that easily removed. For example, we've created assessment units in part to speed the process up, but also to manage things like the European Working Time Directive. We've introduced day surgery to improve the quality of experience, but also to free up beds. Similarly with on the day of admission surgery and so on. So all of these individual changes have been made to improve efficiency and effectiveness of the system, but they come to a point where they create a new set of constraints. So I think we need to think about new solutions to problems and not think that we can easily re-engineer the past because we've changed for relatively logical reasons. And I'm sure you could add to that list. So one of the key points of this talk is we need to not be looking in the rear view mirror. We need to be looking for novel solutions that deal with the current problem, but also take account of the problem we will have in the future because of the population is continuing to change, so that we are taking a medium to long-term view as we're making today's decisions. One of the big challenges that people say is, well, it's all about getting people out into nursing and residential care and getting appropriate levels of domiciliary care. And there's definitely a point in that, but it's not the whole story. This chart just looks at people who were discharged to nursing and residential care, and you can see that there's been a 30% increase in volume, but over the period we're looking at, length of stay has reduced, so total bed use has actually only gone up by 18%, about 1,600 beds, and the improvement potential is about half the increase in work. So it's not to say that we aren't making progress on improving pathways, but we're not making sufficient progress to keep the system in balance. When you compare that 1,600 bed increase to, for example, the space required for the 0-day patients, it's not that far removed. And when you compare it to the likely increase in bed usage for comorbidity, that looks to be about 6,500 beds over the period that this report is based on. So as fast as we are improving, other pressures are moving in the other direction. And that's one of the problems of our planning mindset. We hope that we can improve from where we are, but we don't always weight sufficiently the countervailing forces. So before I come to solutions, I just wanted to pick up on a few thoughts. This challenge that we're all dealing with now to improve flow has emerged over a 3 or 4 year period, and probably we're only just starting to get a really good grip on what's going on to really try and solve it. And I would argue our approach to problem solving has contributed to that. This is a picture of the Constitutional Court in South Africa, and for those of you who have been to Johannesburg and seen this building, you will know it is a very powerful piece of architecture. The picture on the right-hand side illustrates the atrium, and the big pillars that are there are meant to replicate palm trees, and the African tradition apparently of when you have a problem, sitting under a tree and talking about it until it's solved, and the notion of linking that into a court is, and sometimes that can take quite a long time. And so actually sitting and talking and discussing are really, really important parts of problem solving, but doing it purely from a qualitative point of view without bringing some, bringing some data to the discussion is not a good way of doing things. So balancing storytelling with data is something I would strongly advocate. The second part is listening and thinking in a very structured way, and this court is very illustrative of that. The windows you can see just behind where the judges are sitting is symbolic. It allows people to see what's happening in their decision-making chamber as the public, and it's there to act for the public. So it's telling us something very important about the transparency of the process and letting ideas into a space. And it's telling something about reaching a consensus about what needs to happen as a group. So I would argue that where we've got these kind of complex problems, actually thinking a lot about the decision-making environment and how to make it as non-hierarchical as possible offers real opportunities for speeding up the decision-making process. Just moving on to that, and what else is a problem? When Nigel Edwards first started looking at flow in about 2012, one of his key quotes was, "The current data doesn't explain the problem." And that can mean that the data's wrong, but it can also mean that the environment's changing. And so I think we have to use all of our senses to solve problems like this, and absolutely check that the data's telling you what you think. But if it isn't, it's not time to sit back. It's time to think about where we can get new data that does help. Intuition is really, really important, and one of the key messages from this piece of work is that lots of individuals had key parts of the jigsaw. They just didn't have the whole picture. So the challenge of leadership is to build that whole picture in a way that gets appropriate action to happen. And what this story does tell us is that the environment is changing. Those of you who've read the report will see that for the last many years, death rate has been declining in the country. It's now predicted to increase over a very long period. So a lot of the past expectations of continual improvement need to change, and when you get those kinds of inflections in data, it's usually a sign of a significant environmental shift, which means that planning assumptions that are looking backwards won't actually help very much. Which takes us to the latest news. We contributed to this work, but yesterday the House of Commons Health Select Committee issued its latest report on winter pressures, and I think one of their conclusions is really important. It says the response has to focus both on managing the patient's journey through the hospital and on addressing the increasingly inadequate provision of adult and social care services available to enable safe discharge. And I think the key here is we need to be doing both. So most likely the best strategies, I think, are to improve data collection in real time as part of workflow, so not asking people to fill in more forms, designing systems that get the relevant operational information as people do the job, and thinking very differently about long stay patients. Just as a thought, if you could halve the number of people spending over 7 days in hospital, you would actually release something over 30% of the current bed stock, and that would move us from having a bed problem to and probably a flow problem to different ways of organising out of hospital care. So think through as we're moving to solutions how to speed up the journey. Think through that the sort of thing that is required to speed up the journey of somebody spending 10 hours in hospital is highly likely to be different to the needs of somebody with very complex needs. So one size will not fit all. It needs a differentiated and thoughtfully put together approach. So in conclusion, I think the environment is changing very rapidly. We all know that we can't tackle it doing what we are at the moment, and we need to find different ways of managing flow, thinking through the needs of different segments of patients in the system, and in agreement with the Health Select Committee to expand what we do out of hospital. I'll leave you with this picture. That's what comes out of that WASJIG that I started off with. I think it is time to remove the blockages. For those of you who are really interested in improvement, theory of constraints is absolutely central to solving these problems. And you can see in this particular situation, they've dreamt up quite a few. So I'll leave some time for conversation and discussion, and hope that's been really helpful to you. Thank you. Janet, do you want to come in and see if there are any questions?
Hi, thank you so much. That was fascinating presentation. There's been a lot of activity in the chat room, and I wondered if I could just quickly go over to Dom just to get a summary of some of the key things that have come up through the chat room and through Twitter. Over to you, Dom.
Yeah, sorry, just unmuting myself. Apologies, everybody. Yeah, it looks like we're having some interesting conversations. There's one of the questions that come up, Sasha, was what do you think is driving the zero-day patient trend? And then there's obviously a separate conversation, as you can see, around actually real-time tracking.
Yeah, sure. So I think what's driving the trend is multifactorial. So it's not completely clear. I think it's coming from two directions. One is that we're getting better at solving problems faster. So some of the growth is by stopping the need for a 1 or 2 day stay in hospital because we're just much slicker at it. Some of the need is this increasing complexity, and I think GPs are doing a fantastic job of intuitively managing people with increasingly complex needs, but the size of the population with 3, 4, 5 long-term conditions is growing enormously, and you get to a point where you need access to specialist diagnostics, and you need that in a coordinated way, which at this point in time is difficult to do outside a hospital setting. So I would say those are the two key non-elective pressures. On the elective side, again, more and more day surgery is happening, so all of those things are good, but it requires a different standard of flow management and a move towards real-time data to do it slickly, I think. In terms of data collection, I think it's really, really important. A few years ago, I met a chap who was the research director at Microsoft, and he was actually a doctor by training. And we asked him, "Have you got any tools to help manage flow through hospitals?" And he said, well, he'd love to solve that problem. Actually, it was so difficult. It was much easier to actually map traffic flows around Seattle, and at least the staff would get home in time and think about it. And over the last, it's about 5 years ago, I heard that story. Over those 5 years, the ability to get data really cheaply has changed exponentially. So, very few hospitals now don't have Wi-Fi. We've got a whole raft of RFID type of tracking devices. We've got whole new sets of tools around visualizing data, and I think that there is a role for many of these, but it's really, really important to think about the workflow and the experience that we design both for the patients and for the staff. If we simply add this into a chaotic system without thinking about how to simplify, I think we'll end up in a bad place. And just to illustrate that, I asked the designer to have a look at some of the patient flows for complex patients in one of the hospitals I worked in, and he said, Sasha, do you know how many questions your staff are asking patients? And I have to admit I didn't. And the answer was 1,400. And he then told me that 450 of those questions were duplicates, and we'd invented 28 different forms for the staff to fill in. And you can't think that process is going to be very quick, and you can't think that all of those questions are actually going to be that relevant to the safe delivery of care or the efficient delivery of care. So I think we need real-time data, but we really need to think through how to present that to people in a way that's useful to them.
Interesting. Interesting. Christopher Jones has a question, which is a motorway more like the flow of younger under 65 years of age patients rather than the actual flow we see in our hospitals today?
I think it's an interesting rhetorical question. I think the interesting thing about traffic is actually it represents everybody, and I think the flow through a general hospital represents everybody. So you will get some people on a motorway who are just travelling one junction. You'll get some people who probably wouldn't want to be driving next to because they aren't quite as aware and quite as responsive as others. And the same applies in hospitals. I think we've got a vast number of people who are moving very quickly, but we also have some slow ones. So I think it's a reasonable analogy. I think the important point though is it's not just about the people using the service, it's about the interaction between them. So if you think about your own car, it's perfectly capable at travelling at least the speed limit, but if you're stuck in congestion, you're not going to be able to use that potential. So actually it's the interaction between patients that matters as much as the specific types of patients in a flow situation.
Thank you, Sasha. Just one comment I'd like to finish on is Melanie Andrews says that if staff and patients think that beds would be a solution but we can't afford them, then it's a massive barrier. Flow is actually about patient quality safety. Long stays in the hospital for the frail elderly in particular is inherently harmful, and we must value our patients' time. And we need to deliver this message in a strong way that we need to do this because we can't afford more beds.
I think that's a really good point. I know when I suffer poor experience in terms of my time being wasted, it makes me really angry, and it makes me very unhappy in a hospital situation. Yet seeing us do that to people. So I think that notion of valuing firstly the patient's time, but also valuing colleagues' time and working together to create a better experience might well help us solve the resource constraint.
Thank you, Sasha, and thank you for your time. I think some of these other questions have been answered. If I've missed anything off, please let me know in the chat box.
Thank you, Dom. That's really helpful. We're slightly early today, but I just found that presentation fascinating. Lots to learn. Sasha, in terms of moving forward, what do you project for the next year, or couple of years going forward in terms of flow? Do you think we've got the right technology, the right know-how, the right approach to how we manage data to move this to another place so that we won't be sort of having the same conversations in about a couple of more years' time?
That's a challenging question. I think it's going to be really difficult because I think the environmental trends that I started off with in the population section are real. So we are going to have to run faster to stand still. That said, there are significant numbers of really innovative players in the tech sector now who I think have got ideas and approaches that could make a big difference at actually relatively affordable prices. And I also am aware of some really interesting innovation in out of hospital care that's starting to make a big difference, and those sorts of innovations in how do we do rehabilitation, how do we systematically enable people to connect to voluntary help in their communities and so on. So I think for those who are entrepreneurial, those who really want to make a difference, the next 2 years could be really exciting. Yeah, the biggest danger is saying it can't be done or trying to be too cautious. I just think we need big energy and to use the best skills that exist within the health service, but also the best skills that exist without it.
And Sasha, in terms of having like 3 main points that you would make to NHS England and maybe MPs today, what would the 3 main points be following some of the key issues that you've mentioned today around flow?
I think in terms of your last point, I think we have to own the problem as a system, and we have to be really precise about the request to MPs and people outside the system. This is largely a technical problem that we need to have a very clear ask for how would we like our customers to respond, what help do we need from wider society. So I don't think we should ask a panicked or a general question. In terms of within the system, I think my key message is this isn't a time for people to be acting in a hierarchical or a judgmental way. This is a time for people to be acting to bring the knowledge they have to the table and to make sure that we use all of the parts of the jigsaw, not just a few of them, because it is a very complex situation. It's a fast-moving situation, and that implies the need for very active teamwork. So my metaphor for that is the Apollo 13 film for people who've seen it. We need that kind of urgency and that kind of collaboration to really drive innovation and crack this problem.
And I just wanted to go back to your role within Horizons and the Horizons team. How do you think the Horizons team and what we offer can actually try to not necessarily resolve these issues, but really help to bring it right up to the priority list for NHS England to address?
I think in a number of ways, and one of the really interesting things is that there are lots of people very close to the front line, sort of people involved with the School for Healthcare Radicals who have fantastic ideas, and we can help, I think, in convening those ideas and helping people to test them and to put them into action as quickly as possible. The other thing we can do is to share our knowledge of innovation that's happening in the world. And earlier in the week, I was with some European colleagues judging a Connected Health Award that Zimmer Biomet sponsored. And we had ideas from all of the sorts of themes that I talked about earlier on today. So we don't just have to look within the country. There are some really, really interesting ideas emerging right across Europe and indeed around the world. So I think we can share some of those ideas and hopefully get them into action faster.
Fantastic. And that's it for now. Have you got any last minute thoughts that you want to share? Because I think you've taken us through quite a journey today and a lot for us to sort of think and reflect back on. We've got a couple more minutes. Is there any sort of last minute things you want to end with?
I don't think so. I hope that's been really useful. I'm very happy to respond to questions or thoughts that people have after the event, and if there's anything we can do to help, then we're very open to having a conversation about that. So I hope that has been useful, and it's been a pleasure to put together.
I think everybody in the chat room saying thank you. It's been really helpful, really useful, really some lovely positive comments coming through on the chat room. So thank you very much. We do appreciate you sharing all your expertise and experience with us today. I can just move on to the last slide where we're just going to be talking about the next Edge Talks, which is coming up shortly. Can we move to the next one? Here it is. So the next Edge Talk session is going to be featuring empowering people to be heard and helping leaders to listen. And we've got Dr. Peter Thumond and Dr. Joanne Billingham, who's going to be with us in the next session. So we look forward to seeing them and hearing more about this fascinating subject. So look forward for you coming on the next Edge Talk session, and hope you have a fantastic weekend, and thank you so much for contributing and supporting this session today. So thank you to everybody. Goodbye and have a good weekend. Bye.
Thank you, Janet. Bye.
Bye-bye.